Yep.
All right. All right. So quickly to go over our objective in developing this, we wanted, this measure should give you, number one, an empirical battery for intake assessment. So something empirically derived, something that is standardized across all intakes so that everybody in your clinic is following the same procedure for every intake. There are some exceptions to this that we'll go over later, some individuals for whom this may not be appropriate, but by and large, for most adults, this should be appropriate. In the Stony Brook Clinic, we've been sending out invitations to new intakes to complete these measures before their first intake appointment. And the point of that is so that providers have information before the patient comes in the door about what the relevant problem may be. And this is meant to save time so that the interview can largely focus on the symptoms that the patient has and not symptoms that they don't have. So it is meant to save time, not only because the interview can be honed to relevant symptom domains, but also in that the provider doesn't have to hand score any assessment. So everything that we're rolling out is scored automatically. The results are sent to providers automatically, and they can be uploaded into the electronic medical record, including any intake paperwork that you may have. So I know at Stony Brook, the entire consent process is going to be moved online for both the adult outpatient clinic and the psychology clinic, so that there's no paperwork for individuals to complete when they come in. I know in our clinic, this is a common problem that people don't complete the intake paperwork before their appointment. And so part of the hour or hour and a half set aside for the intake gets spent filling out paperwork. So this should avoid that. In addition, for those of you who will have a longitudinal module enabled, this will allow for an automatic assessment of treatment outcomes. So this will be done at the adult outpatient clinic at Stony Brook, where quarterly patients will have various subsets of the assessment redeployed, and results will be tracked alongside the baseline results so that hopefully we see.
Hold on, okay, grab that.
So the areas of psychopathology that are covered by this assessment are based on the hierarchical taxonomy of psychopathology. Imagine many of you are familiar with it, but if you're not, you can see the sort of landmark paper in AJP in 2017 by Roman, and as well as numerous other individuals on this call. This is an empirically based model of psychopathology. And importantly, what you'll see is that there are various levels of the hierarchy at which one can conceptualize psychopathology, starting with the highest dimension being the general factor, breaking down into the major spectra of somatoform internalizing, thought disorder, disinhibition, antagonism, and detachment, and then into more and more specific facets as you go down. And you'll see in the battery that we've assembled here, there are measures of psychopathology at various levels of this hierarchy. So this is the coverage that we're trying to get. Again, it's various clinics. If you drop certain measures from the battery, you may get different parts, different coverage of different parts, but theoretically, you can cover the major spectra with this battery. So to do that, we've assembled this subset of tests. So first, the inventory of depression and anxiety symptoms. This is an assessment of internalizing, going back to this figure, so the sort of first block of symptoms over the past 2 weeks. We have the audit and DUDIT for alcohol and drug use related problems. These measures are can be assessed over the past year or the past month. Self-reported psychotic symptoms in the CAPE. The CAPE has both positive, negative, and depressive subscales. Here we've included only the positive subscale. at all sites because depression and detachment and negative symptoms are covered well by other measures in the battery. So to save time, we've gone down to just the CAPE. At UNT and some other sites, we have the PHQ, which is a measure of somatic concerns over the past week. A core part of the battery is the CAT-PD, which is a measure of, in fact, the sort of 5 superspectra here at a stable trait level. So these items are assessed, are asked about a person in general as they compare to the general population over a long period of time. And then finally, psychosocial impairment. So how are they getting along in life in the past month, given all the symptoms assessed by those 6 measures? So if you have all these measures together, it'll take 45 minutes to complete on average. For some people, it may be considerably longer if they're a slow reader, but also for some people, it will be considerably faster. There's a pretty wide range of how long this takes. And even with most of these measures at Stony Brook, we've had people completing this in under 30 minutes. Also, the battery individual can leave and come back and complete the battery at a later time. So there's no need for them to complete it all in one go. So time to completion ranges from 25 minutes to, the 3 days that somebody took to stop and do something else and come back at a later time. So the logistics of doing this, I mentioned this is not applicable to every patient, although we think it's applicable to most adult patients. The individual has to be fluent in English, be at least at the 6th grade reading level, and over 18. And that's primarily because all of the information is normed, all of the scales are normed in comparison to adults. So we do not yet have child norms implemented for any of these. We do hope to develop a child measure in the future, but currently this is just for adults. But for everybody for whom this is applicable, this is sort of the logistics of the assessment. At Stony Brook, the assessment is sent out, the invitation is sent to the patient's email at the time that they schedule intake. They can complete it then, or if they don't complete it then, they'll get a reminder a week before their first intake appointment. As soon as they complete the assessment, the results are automatically tabulated and sent to the provider. And at our institution, this will depend a little bit on rules about your particular EMR, but in our institution, our providers have been appending the results that they get via email to their intake report, so psychological intake. So that's sort of how we've been doing this at Stony Brook. Again, it will vary. I know at some sites, providers are sending out the invitation themselves to their patients. In some sites, it is somebody front office staff who's doing this, so it may vary from site to site. This is what it looks like for the patient if they're completing the assessment on a desktop computer. Of course, if you have this operating at your own site, you'll have different sort of color schemes and logos. That is all automatic, so don't worry. They will not think that they are being seen at Stony Brook University. There's also a pretty good mobile interface. This will vary somewhat depending on, again, what specific modules you have implemented at your site. This is the Qualtrics interface in both of these examples. The user interface is a little bit nicer than the REDCap version, but the REDCap is also mobile ready. So for both of these, you can, participants or patients can complete at a desktop or on their phone. All right, so an important part of this system, as we've rolled out at Stony Brook, has been the assessment of suicide and self-harm. So again, I'm just going to talk about how we are managing this at our clinic based on New York laws about mental health professionals and duty to report. as well as our specific, this will vary somewhat by the specific rules of your clinic and when an individual is considered a patient in your clinic. So in our clinic, patients are not, individuals are not actually a patient at the clinic until after their second intake, when a treatment plan has been formulated. So prior to that point, and when providers get this information, which is before the first appointment, the patient is not actually a patient of the clinic. So according to New York state law, our providers don't have a duty to report in cases like this. It is permissive. They are allowed to intervene in cases like this, but they are not mandated to do so. So based on that information, we've developed flags or alerts that are triggered when an individual reports suicide or self-harm at a level above 1.5 standard deviations of the population mean. So this is relatively conservative. You could set the threshold at 2 standard deviations, but we thought better to identify all people at risk and be on the safe side. So 1.5 standard deviations is 84th percentile. If an individual has symptoms at this level, they'll receive an email reminding them that their provider will not be reviewing the results immediately and providing them with some resources in case of a crisis, local resources. This is a sort of generic message, but it is adapted to each clinic to have local resources. So they'll receive that email. The provider will also receive an email with the individual's responses to every item on these scales, so they can judge for themselves what specific behaviors are relevant to this person and decide on what they want to do about this information. The individual will also receive a little pop-up on the screen when they complete the assessment, saying with the same message that is posted to their email address. So again, this has been reviewed by our legal team at Stony Brook, but it varies by state and by clinic. So an important thing to kind of decide based on your local context. Again, so we've been pretty conservative. Out of the 50 patients that went through this process during our trial period, 10 of them had an alert that was triggered because of high scale scores on these measures. In only one case was the risk deemed to be of a level that providers felt it was important to do something. There are a number of things you can do. One would be to do nothing and follow up at intake with specific questions about suicide and self-harm. At a higher level of risk, what we've done in our clinic is reschedule the intake appointment so that it occurs relatively soon after this is complete. See if we can bump the intake appointment up. And at another level of severity, you might call and follow up with the person over the phone and see if they are indeed in crisis, and then again, direct them to the appropriate resources. Again, we haven't had that happen in our clinic. We've had one individual during the trial period, which is now probably more like 60 or 70 people who have come through this process, for whom we decided to move up the intake appointment. Okay. So any questions about that? Because I just know that has been an issue, especially of concern for providers, and best to maybe take some questions now. No? Okay, all right, oops, scroll too much. All right, so we'll go a little bit over the results, what they look like. At each site, I know Camilo and David have a, I'm gonna switch over to the trait definitions. This is provided to everybody using the intake assessment. This includes a definition of every scale that's in the measure. So we have CAT-PD scales, which again are those stable personality traits, grouped into the 5 spectra that measure assesses. So negative emotionality, detachment, psychoticism, disconstraint, antagonism, and then the IDAS, so these depression and anxiety symptoms, grouped into symptoms of distress. It's a more general depressive symptoms. And then fear, these are more the phobias, as well as some symptoms of PTSD. And then mania. Depending on your clinical sample, you may find that you have few people with elevations on mania, and that this is most often not elevated, but actually very low in individuals with depression. So we'll go over that in an example in a moment. The CAPE, the Community Assessment of Psychic Experiences, some symptoms of psychosis at both the threshold level of outright hallucinations and delusions, to more subthreshold symptoms like unusual beliefs and experiences, some eccentricity, peculiarity. The audit and the drug use version of the audit, and again, the somatic symptoms assessed by the PHQ and disability assessed by the HuDAS. So I won't go into great detail about all of these spectra, but just very briefly, all of these are scaled on a T-score metric. So that is a mean of 50 and a standard deviation of 10. So in general, again, we've been somewhat conservative. We consider, or for the purposes of today, I'm considering an elevation anything greater than a score of 65 or 1.5 standard deviations. In a few cases, for a few scales, such as the mania scales, scores greater than 1.5 standard deviations below the mean are also interpretable, but in general, they are not bipolar scales. Bipolar in the sense of they don't have meaning at both ends of severity, just 65 and greater, with the exception of those mania scales. All right, so we're gonna go back to the system. So this is what the text-based report looks like for the provider. So this is, again, emailed to the provider immediately upon completion of the assessment by the patient. I'm just showing the first few rows here because it is, quite, there are a number of scales. So we're just showing the IDAS here, including, so the scale name on the left grouped into various domains. Percent completed is the percentage of items within that scale that the individual has completed. Currently, this is just available in the Qualtrics version, which is being deployed at UNT, but not the REDCap version of the assessment. This is primarily intended to help providers identify individuals who are not completing the assessment in full, and therefore maybe their scores on certain scales should be interpreted with caution. So for example, we've had a number of individuals who have not answered items about alcohol and drug use, which usually indicates that, that's something to follow up on the intake appointment. On the other hand, sometimes we've had people who've responded to just a few items with rather, resulting in a rather severe score. Again, something to follow up on if the few items that they're endorsing a high level of use or high level of severity, it's worth following up on that area. Some of these are more socially acceptable or more stigmatized than others, particularly psychotic experiences and drug and alcohol abuse are somewhat stigmatized. So obviously also self-harm and suicidal thinking, sometimes people don't want to answer those questions due to concerns over what might happen if they do. So in general, those are just to alert the provider that a person has not completed all the items and maybe they should be followed up on. We also, the the suicidal thinking and self-harm scales, that the alert that pops up is triggered if the T-score is greater than 65, but also if the person has not completed any items on those scales. So if they've completely avoided answering questions about that content, also is a sign to maybe follow up at intake, if nothing else. Okay. So I said these are all scored on a T metric. That's not entirely true. The audit and the due date, we're currently reporting raw scores, and that is because it is, number one, difficult to find good norms, but number two, those are very often interpreted, or the normative data available have been based on cutoffs for men and women. So rather than, you could develop some sort of conditional scoring to develop a T-score that is normed separately for men and for women, but right now we're just reporting the raw scores. This may also be beneficial if you, as we do at Stony Brook, have to complete the audit and for various insurance reasons. So in our clinic, the audit has to be completed, or a subset of items from the audit have to be completed regularly for electronic medical records and insurance purposes. So we've included the raw scores as well as the individual item responses at the bottom of the report so that clinicians don't have to ask those questions again when the patient comes in for their intake. So this is, again, what the text-based report looks like for providers. We also have the option, which I believe may be implemented at Stony Brook, but is not implemented at UNT, for a visual report in which scale scores are plotted graphically. So here we've divided things into state and trait scores based on the time frame assessed by the measure. So state measures are generally measures of symptoms in the past weeks or month, and trait measures are those that assess symptoms or long-standing, more stable predispositions to psychopathology. And then at the bottom you have, again, the audit and the due date reported on the raw scale with thresholds for men and women separately. So again, this might differ based on what measures you have available at your site, but both the text and the visual report are available for anybody who's interested in using them. You do need a Tableau license at your institution to use the visual report to implement it. So I'm just going to walk through a case study briefly to get a sense of how this might be used in clinical practice. So we're going to look at results from a woman who we know very little about, and this is sort of purposeful because, again, at our clinic, we're rolling this out, and at most clinics, as an assessment that's done before the intake appointment. So you may, our providers may have very little information about the individual prior to meeting them. So this is a set of results from a 22-year-old Caucasian woman who's a college student living in an off-campus apartment with 3 female roommates. This is not her first time in treatment. She has a history of depression, anxiety, and relationship problems. And her sort of reporting complaint is that she feels like her life is sort of out of control and she just wants it to stop. So we're going to look at the text-based results, the text-based report for her. Okay. Okay, and again, just going to go down the list here. I'm going to actually skip down to the results for the CAT PD because that, sorry, somebody asked what kind of license do you need to use the visual report? Yeah, you'll need a Tableau license. We use that for various purposes at Stony Brook, so that has been very fairly easy for our providers already use Tableau for tracking various metrics like their patient hours, etc. So they're familiar with it. It is not hard to use. The way that visual reporting works is there's a text box at the top of the window where you type in the MRN and then the data pops up. Okay, so I'm going to go down to the CAT-PD results because these are sort of, again, more stable predispositions for psychopathology that an individual might have, and they're organized by domain. So we'll go first through negative emotionality. The negative emotionality T-score is elevated, so that kind of sends a signal that, you know, this person has a sort of broad predisposition to negative emotional experiences, and most of the more specific facets that comprise negative emotionality, including affective lability, so a quick changes in mood and a sort of feeling that one cannot control those changes. It's really important that it's not just mood swings, but these items are really more about, like, I can't cope with my changing mood, or my mood swings are out of control. Anxiety and depressiveness, those are more straightforward, but tendency to these symptoms consistent with what we know from the medical record. Again, self-harm, we'll go into these items more in a moment, but also mistrust, submissiveness, and relationship insecurity, again, consistent with what this person said about having a history of relationship problems and unstable relationships, as well as some cognitive problems. So cognitive problems can be, as you probably know, caused by a lot of different forms of psychopathology, but very often people who are depressed have a hard time concentrating, in part because they're having negative thoughts intruding on their other thought processes. So that can be elevated for that reason. This person also is elevated in the spectra of the detachment spectrum. So this is different, I think, importantly, from social anxiety, which is covered by the IDAS. So this is more of a almost difficulty connecting to other people, and in some cases a disinterest in connecting with other individuals. So this person is somewhat distant. More specifically, they don't get much joy out of social relationships. They're generally withdrawn in their social relationships. They may not be interacting much with others, and there's not a lot of emotional closeness. All right. So the psychoticism spectrum is not elevated, but they have more specific elevations. These are somewhat mild relative to negative emotionality. So I think one advantage of the system above, let's say, like a diagnostic breakdown or list of diagnoses, is that the T-scores do help you prioritize this, what is most problematic for this person, which is depression, self-harm, submissiveness, and these cognitive problems. And less so, these are elevations, but again, they're relatively mild. The detachment spectra, it's relatively mild elevations in comparison to negative emotionality. So they have some fantasy proneness, some peculiarity, but again, these are not severe things relative to the other problems. And then disconstraint. Disconstraint, again, not an elevated spectrum score, but some specific problems relating to impulsivity. So again, this is one of the bipolar scales in the assessment, or rather within disconstraint are scales assessing both the lack of the lack of conscientiousness and a sort of too much conscientiousness, perfectionism, workaholism, and rigidity. So this person has sort of a lack of constraint, and they're acting impulsively. Again, compared to the negative emotionality, this is not the primary concern that this person has. All right, and then not an elevated antagonism score, but again, some specific problems relating to manipulativeness and norm violation. So this might be related to the person's relationship problems. Okay, so since the person was saying that they have this sort of long-standing predisposition for negative emotionality, I'm going to go to the IDAS, because that is sort of the best state measure of negative emotionality in the battery. So this will give us a sense of, okay, given that she's somebody with a long-standing predisposition to these symptoms, how is she doing right now relative to that? So I'm going to go back up to the top. So you can see that in general, so here we're breaking it down a little bit more into distress and fear. So this is not, she doesn't have a lot of negative emotionality because she has maybe, PTSD or specific phobia or social anxiety, like I was discussing before. This is more depression, anhedonia, and in particular, this low mood dysphoria. An important sort of caveat here is that general depression is a scale score that is in part comprised of items that are in these other scales. So, so just to be aware that it is somewhat redundant with the others. But the items in this scale map pretty closely onto the symptoms of depression, as in the DSM. So it's just more sort of honed towards that conceptualization of depression. So you have low mood, difficulty sleeping, an increase in appetite, irritability, and traumatic intrusions. Again, this isn't necessarily PTSD. Oftentimes, this is more perhaps consistent with the cognitive problems that she reported on the CAT PD, the sort of intrusive negative thoughts. So again, you can't really call this PTSD unless you did a very careful interview about, what the traumatic event was and what her particular concerns are now, and are they related to the traumatic event. So I would say more interpret this as just, again, concentration difficulty, particularly relating to negative thoughts intruding upon her thought process.
I can also add on the IDAS that if you're used to using BDI and perhaps BAI, the general depression is basically a clone of BDI. It's done differently, but they correlate very highly, so you'll get the same information. And IDAS panic is very strongly related to BAI, so also a good stand-in there. Really, any screener that routine may be required, or maybe you've used routinely, even PHQ-9, CSD, etc. General depression, good replacement for them, can work at least as a replacement. Just to throw this in.
Yeah, that's a good point. Thanks, Roman. Yeah, in terms of connections to other measures you may be very familiar with already. Right, so she doesn't have very many specific fears or phobias, no symptoms of OCD, but again, that's consistent with the CAT PD. She didn't have that sort of problem of over constraint. And here in mania, again, no manic symptoms, more that she's very low on this scale. So again, consider abnormal, maybe any score greater than 1.5 standard deviations below the mean. So anything below a 35, and she's quite far. In fact, I think this may be the lowest score that you can get on this scale. I'm not sure. It might be 28, but I think 30 may be as low as it goes. So she's not not experiencing many positive emotions at all. All right. So on to the audit and due date. Her case is somewhat complicated by a pretty high score on the due date. Of course, you can go much higher, but technically elevated and should be evaluated for drug use problems. So the way that we've implemented the due date here is that individuals are asked to describe their use of drugs generally, rather than their use of any one specific drug. And they're not queried on what specific drug they're using. So this is something that would be very important to follow up on the intake. What kind of drugs is she using? Are they something that might partially explain her symptoms, or are they something that maybe are partially, at least she believes, counteracting her symptoms right now? We don't know. But the specific behaviors are listed at the bottom of this report. So I'm going to go down there. Again, not the audit because she's not using alcohol. In the due here's somebody who seems to be using, not regularly, but when she's using quite heavily. So she's using maybe two, as she says here, a few times a month, maybe weekly at the most. But when she does, she's using them something somewhat heavily, and in some cases, it's causing some impairment in her life. She doesn't do things that she has to do, or she feels bad about it. So this is something that is clearly causing a problem for her, but further follow-up is needed to identify exactly what substance she's using. I would say this pattern of use, again, this is, we're not really, we're not collecting data over time. So that's one of the benefits of a longitudinal assessment, is you can kind of begin to look at what, do symptoms tend to precede changes in drug use or vice versa. But in her case, I would say this pattern of use of occasionally using heavily is consistent with what we saw in the CAT PD, of his problems with disconstraint. So less of a compulsive user and maybe more of an opportunistic user, or somebody who's easily convinced to use more, or when she starts using, uses more. So consistent with those problems with disconstraint there. Okay, so again, she had some peculiarity, but just to go through the remaining scales, she doesn't have an elevation on positive symptoms, so I'm not particularly concerned about a psychotic disorder for this individual. And she's functioning fairly well, given that she's still a student. Maybe this is not surprising, but she does have some level of functional impairment due to these symptoms. So I would say that this is somebody, the primary problems from my perspective reading this are, this is somebody whose primary elevation is in this trait, negative emotionality, somebody who's very predisposed to negative experiences. And her problems right now are actually, her acute symptoms are maybe less elevated than you would expect them to be. But she has this long-standing predisposition, and that is something to pay attention to in treatment. It's not just treating her immediate symptoms, but trying to develop some skills for addressing these problems when they arise, because at least given the results of the CAT PD, it suggests she might be somebody who would have consistent problems in this area, who might have multiple episodes of depression. Again, we know from her history, but again, going forward, be careful not to think that, because her immediate symptoms may be alleviated relatively soon, keep an eye out for relapse and work on changing these more long-standing patterns. So again, and this is somebody who had elevations on two other things to point out here: the fantasy proneness and peculiarity that are not verified, that don't seem to be outright psychotic symptoms based on the results of the CAPE, but also she had some suicidal, some self-harm, problems with self-harm. Actually, that is her highest elevation, as well as she's just under the threshold on suicidality. So let's look at her let's look at those items to get a better sense of what exactly thoughts and behaviors she's reporting. So these are the critical items. And let's see. Okay. All right, so self-harm. Seems like somebody who's engaging in self-harm behaviors and has these particularly, I don't know if these are related maybe to her intrusive thoughts, but thoughts about hurting herself, thoughts about killing herself, and some form of self-harm. Well, there's a little inconsistency here, that here it says that she hasn't cut herself, and here she says that she has. So again, I think this would be obviously important to follow up on the intake. What specific behaviors is she engaging in, and at what intervals? She's having thoughts about killing herself, but she has not written a note. It would be important. This is, again, a lot of these items are about thoughts and feelings regarding self-harm and suicide. I think, a really important set of follow-up questions is about intent and plan, and reasons for staying alive that the person has. So those would be very important follow-up questions. I think in some cases, when an individual is reporting all of these, endorsing all of these items, you can be, that's certainly cause for alarm. But I think it's also important to conceptualize this assessment, that there's also a much higher level of severity that maybe isn't assessed by these items, and just be mindful of that as something that's not explicitly assessed here. Suicidal or self-harm, actual behaviors, very few of them, and behaviors relating to suicide or suicide attempts. And again, also, especially the IDAS, these are all in the last 2 weeks, so we're not getting at a history of suicide or self-harm, so to say. So again, just some things to be aware of, things that this assessment does not capture that would be important to follow up on intake. So again, we're not trying to, the point of the HiTOP assessment is that it's to develop something of an alternative to a SCID and let's say a list of diagnoses. I will say that given this person's sort of broad, the number of scales that are elevated across various broad domains, I might be somewhat concerned or considering that maybe this person has symptoms of personality disorder, maybe borderline personality disorder. Again, you don't want to sort of jump to that from the self-harm and suicidal scales, but the combination of that and sort of the broad range of psychopathology endorsed suggests that maybe this person, clearly this person is under a lot of distress, and that the assessment sort of communicates that to you, the provider. So again, I actually don't have follow-up information on this person, so I don't know, what her actual, let's say, diagnosis would be in the medical record, but just based on what we do know of her, that is sort of something that I'd be considering. And it seems important that there's this combination of negative emotionality and disconstraint. So somebody who feels bad and occasionally acts impulsively, and it might be worthwhile trying to disentangle how those two factors play into one another. Does this person use drugs when she is feeling bad, or also she endorsed items about feeling guilty about using drugs? So I'm sure it's, obviously probably a relationship, a mutually reinforcing relationship, but that would be sort of the direction of inquiry that I would take on an interview with this individual. Okay. So we've got about 10 minutes left. So I'd like to take any questions that people might have about this assessment. Or Roman, if I've missed anything, please feel free to speak up.
I think questions are very important, so I will just say for 10 seconds that I think it's very efficient a very efficient instrument. So you get a lot of information for little time. It may be overwhelming in a way, but it's my graduate school experience. I think it's worth it. My graduate school experience was to give them MPI for an hour, then spend an hour scoring it, and then you get 10 scales out of this. Here, you send a link and 53 scales come back. It's pretty much a comprehensive assessment of the person. But let's turn over to questions.
This is not technically a question, but I just wanted to say that Catherine, Roman, Camilo, David, and anyone else who's worked on this, it is an amazing thing. Thank you so much for your effort. It is going to be revolutionary. Not technically a question, but good job. And was that question enough? There we go.
Yes, in answer to your question, Nick, it was. No, we're really glad that people are finding this useful. And we're looking forward to seeing more clinics use it. I did forget to point out one thing that we're working towards, obviously, within the consortium is development of a HiTOP measure. So right now we have the sort of array of this battery of measures that covers the entire spectrum, but what we'd like to do is, they've all been, of course, normed in different populations. And if you want more information about what norms we're using, I'm happy to send that. But what the consortium is currently working on is development of a comprehensive self-report and compatible clinical interview that will cover the same domains, but I think likely in a more efficient way, because despite trying to remove various overlap between scales, I think that there still is some in this battery, and that'll be removed in the HiTOP. So when that's available, I think we'll make available a version of this measure where the system is very much the same, but the content is the HiTOP assessment battery, rather than what we have here, which is a sort of HiTOP consistent assessment battery. So any other questions, particularly among providers, those of you who might have to use it?
This is Colleen. I have a question, if that's okay.
Yeah, of course.
One of the things I liked about the battery here is that, you know, not all clients would have to, or patients would have to take every scale. Mm-hmm. Is that something that they would just scroll through, or is it possible to customize so that they don't even see those particular items?
So right now we have, the battery is adaptable on a clinic basis. So so unfortunately not.
Yes, clinic basis. Got it. That's that's relevant.
Yeah, I know, for example, our Stony Brook Psychology Clinic is not going to include the assessment of psychotic symptoms because that is very infrequent in their patient population. Are there any specific concerns that you have about your patient population, and maybe parts of this would be?
It's exactly what you just said, which is working with a population that is we screen out folks who, this is a university training clinic for doctoral students, screen out clients who are on the severe end. And then are any of the measures, like I know it says % completed, which is really useful. Will it still give a T-score if not enough of the measure has been completed?
Yes, yeah. So currently it does provide a T-score even for those that are not entirely complete. So it's more of a qualifier than an exclusion criteria.
Okay, thanks.
Yeah.
Hey, Catherine, this is Camilo. Can you hear me?
Yes, hi, Camilo.
Oh, sorry, I have really spotty internet, so I'm sorry that I haven't been able to join the whole time. Let me just make a couple of comments for those at UNT. One is that we are making available, Yulia right now is working on a visual version that we can use in Excel that looks like the Tableau one. And we have previous visual versions. So it will be a visual report available for UNT users. And we're working with the test store room to make that available to all clinicians. We have a research version right now that anybody can start using today, but the clinical version through the test storeroom will be available hopefully within the next few days or week. So I just wanted to make that comment. The other comment I wanted to make was that we have played around with making modular versions of this battery, but we haven't had people request it, and so we haven't been doing it initially, but I think in the future that will be available.
Yeah, that is one advantage of using the REDCap version. While we can't, so a few things that are possible, although not currently implemented in the REDCap version. REDCap can do computer adaptive testing, which would theoretically allow you to, you know, reduce the number of items that a person would answer relating to symptoms that they don't have. But in addition, with REDCap, if you're using the longitudinal follow-up assessment, those longitudinal assessments can be dependent on a person's score at baseline. So if they had a high score of on depression at baseline, you could re-administer preferentially the IDAS, but let's say not the psychoticism scales of the CAT-PD. Similarly, you can also set certain modules to be reassessed regardless of a person's T-score. So maybe you want to keep an eye out for emergent substance use problems. That module can be repeated at every follow-up. So I am hopeful that that will also be something that we can implement in Qualtrics for you at UNT as well soon. But currently, the functionality for longitudinal follow-ups in Qualtrics is not great, and they have to be administered sort of as a separate measure, but it could be done. It would require a little bit more manual work, but it could be done.
Let me really underscore the point that it's not going to be a whole 45 minutes at that point.
Yeah.
It will be like at the most IDAS and probably even not, and plus maybe substance, and not the whole thing even. But anyways, that.
Oh, Roman, you've dropped out.
Oh, sorry. Future implementations. I wonder if folks see any questions as far as logistics, like if you were to use it tomorrow, or maybe some hesitations about using it tomorrow.
Yeah, and I do, Roman, I want to hear those questions, but let me underscore to the folks from UNT. Starting, you can send a link to your clients, or have the test room by Monday send a link to your clients, and you will receive a full report. So it's that easy. If you have any questions about that, you can email me or David.
Yeah, and I think at Stony Brook for the psychology clinic, my understanding is it will be a little bit more standard in that when intakes are scheduled, this will be sent out to patients, to everybody coming through this psychology intake system. So that will just be delivered to you automatically. And I also see, Colleen, your question here in the chat. To access the battery, you know, if this is something your clinic is interested in, we'll just talk a little bit more about what tests you want. I'll basically subset this so that you have the number of tests that you want, and then I'll send you the full Qualtrics file, which you can just upload into Qualtrics, and it should be pretty much ready to go. There are a few elements that need to be set up, like the local resources for a suicidal crisis.
Sure.
Just little bits of information that need to be put in, but
Okay.
it's pretty short. I would say it will maybe take 20-25 minutes to set up if you have everything on hand.
Great. Yeah, we'll just be in touch, and this is so awesome. I'm really excited about it.
Great. We're wonderful. We're really excited too. All right. Any other questions? Again, feel free to reach out, of course, to those of you at UNT, to Camilo and David, but also to me. I'm at Catherine, Katherine, .Jonas, Jonas, at Stony Brook Medicine. I think most of you have my email address. And again, also feel free to forward this information, or put anybody, if you know of other clinics you think are interested, put them in touch with me or Roman. Or Camilo, and we can get this rolled out. We're happy to see as many clinics using it as would find it useful.
Just to add, we have this recorded, so we'll be sending out information soon about how to access that.
All right. Well, it's been wonderful seeing all of you, those who I can see, some familiar faces. Thanks so much for being here. And again, yeah, please feel free to be in touch. All right, wrap it up. All right, good night, everybody.
Okay, great. Thanks, Catherine.
Thanks, David.